wasn't about the coding as much as the billing, right? You know, how do we build this? Of course, the coding is important, but I know, and I think Jennifer understood that way too, that, you know, how this isn't lining up. How are we going to get paid for what they've done? Are we capturing everything that they did? It's pretty intense, okay? But look at the codes. I looked at that and I said, the first thing that I said to myself was, oh, this must be an old scenario, because those are ICD-9 codes, you know, the three, you know, 3 digits and then 2. And I thought, well, maybe they just put the 3 in there because it couldn't be 170.213. It would have to be, if you remember ICD-9, you can only have 5 characters. You can't have 6. And so I put in the 173.9 in to find a code, and I was thinking to myself, well, that's a cancer code, because codes, even with, you know, well, not so much with ICD-10, but with ICD-9, the codes at the beginning, any codes that kind of started with a 1, and some that started with a 2 were cancer codes. If you started with a 0, then they were the, you know, the bacterias and the types of viruses, et cetera, because ICD-9 and ICD-10 both follow each other the same, right? Even though the codes change, the, how would I say that? The demographics, maybe the geographics of the codes, it's, you know, still like in an order, and everything's predominantly the same. So bacterias and infections and things are still in ICD-9 and was in ICD, in ICD-10, still with ICD-9 as well. They're at the front, you know, and then the causal codes and stuff like that are all at the back. So I looked at this and I thought, wait, why would you be doing all those procedures for cancer? But I thought, well, I'll look it up anyway. And sure enough, it was some type of cancer, but it wasn't clicking in my head. And I thought, wait a minute, 170.21 doesn't really, it exists, but there's definitely not a 3. And then it dawned on me, and mind you, this is the report that I'm sure she copied and pasted. It's not a 1. That's supposed to be an I. All right. So it's I73, which would be something to do with the vascular system, ischemic, something, you know, to do with the heart or the vascular system. And so again, that is clearly a 1, but those are I codes. So when you look them up as I codes, it makes sense. What does that say about the documentation for the platform that they were using? I don't know, but it was kind of curious. So we will be dealing with those. I'm not even going to read these codes because, again, we're going to go through it step by step. Just kind of wanted to highlight how it would look in the documentation. It can be very, very confusing. Now, if you're new to this, do not get intimidated by what I just said to you. For the most part, you're not going to get documentation like that. And when you work someplace, the documentation is very repetitive. And so you'll see it again and again and again. You'll get a feel for the way that your provider documents. So, you know, again, don't let that intimidate you. Just be aware that everybody documents a little bit different, and the EMRs come out kind of wonky sometimes. So what I did first was think, we got to explain what an angiogram is. Very, very important. And there's something specific about angiograms that you need to know. So I made sure I underlined those. In the documentation, sometimes they break it down and just call it an angio, but they mean an angiogram. Medical field likes to shorten everything because it could be an angioplasty. So it's not a good thing to say an angio just by itself. An angio by itself is not proper documentation. Just be aware that even this particular provider, who's a specialist in this area, was saying, hey, this is also called an angio, or referred to an angio. I pulled this directly from this that website that he did this statement on, and I've also put that in the resources on that last page. So feel free to go in and look at that. It was a really good website. So Dr. Luke K. Marone explains an angiogram this way. And the key words that I want to pop out at you is the fact that it is an X-ray procedure. Now, if it's an X-ray procedure, where's it being done at? Interventional radiology. This is not your regular radiology department where you go in and they X-ray fractures. They usually, if you have a department that's doing this, you'll have radiology and you'll have interventional radiology, okay? 2 different rooms, because often, look down here at the bottom, you're sedated, okay? So it's a little bit different. They're going to do a procedure, but it's an X-ray procedure, and you need to know that it can be both diagnostic and therapeutic. Why is that important to understand that? Because it changes the code itself. Some CPT codes are just for diagnosis, and others are for therapeutic, which ultimately means you're correcting something. It's a procedure, you're fixing it. So are you going to go in to determine what the problem is, or are you going to go in and fix a problem that you already are aware of? Or number 3, third choice, are you going to go in, find out what the problem is, and fix it at the time that you become aware of it? And all of that makes a difference in the codes that you use. Sometimes you'll have a code that is for both diagnostic and therapeutic, and sometimes you'll have a code that's just diagnostic and therapeutic. Be aware that that happens in other areas of CPT, not just in interventional radiology or X-ray procedures, right? You'll see that often in your CPT manual. It makes a difference whether it's diagnostic, therapeutic, or both. Okay, so it is considered a gold standard, which means that you're going to see it a lot. It's a procedure that's done very often. It's used for evaluating blockages and in the arterial system because it's an angiogram, right? The angiogram detects blockages using the X-ray taken during injection of contrast. Very important. So they're using a contrast agent, usually iodine dye. But when you look at the CPT code, it will say often with CPT codes with or without contrast. So you may have a code that's with contrast only. You may have a code that is without contrast, or you may have a code that states with or without contrast. You can use this code, just like diagnostic or therapeutic. So now you get an idea of how these codes are detailed and listed and can be convoluted. If you do not pay attention to the details of the description of the code, you can trip up real quickly. Don't let that intimidate you because it's right there in front of you. You just need to slow down, take a breath, and say, oh, wait, I'm aware that it could be diagnostic or therapeutic. Oh, are we using contrast? Does this code that I'm looking at, is that with or without? You know, so again, as long as you're aware of those things, you won't trip up. This is another reason why you BAT technique your manual, because these are the specific things that you're going to make note of around those CPT codes. It's going to make you faster and it's going to make you more accurate. You're going to be less likely to make a mistake. And these are exactly classic ways to write exam questions to see if you know the difference or if you're paying attention. They are not trying to trick you up. They are strictly saying, hey, does this person, are they aware that we have a code that's with contrast or without contrast, or that they know that this particular code is with or without, so it doesn't matter. If I'm writing a test question, that's exactly what I'm going to test you on. You got to come up with 3 out of 4 choices that are wrong, right? So angiograms, oh, wait, let me go to the next sentence. The procedure provides information that helps your vascular surgeon determine the best treatment for you because it's a diagnostic. So we're going in, we're going to look and see what the problem is. It's usually trying to be aware of a blockage of some type. Not all the time, but most of the time it's some type of a blockage. Angiograms are typically performed while you are sedated. The reason I thought that was important is that that means that you could have a anesthesiologist involved, a nurse anesthetist. Now, that would not be coded with the op report. They have their own reporting and coding that goes along with that. So you won't, when somebody comes in to have an angiogram and you're coding the angiogram, you're not going to code the sedation, right? The nurse practitioner will write a report and you would code it off of that if you're coding for anesthesiology. So I do know that some people get confused with that when they're starting out. They'll try to say, they'll tell themselves, oh, well, they used XYZ sedation and I need to go put an anesthesiology code in there, but that is not what we're doing. Okay, two separate things, two separate procedures that you're coding: the angiogram and the sedation that is used during a procedure. And it's usually 15-20 minutes, especially if it's just diagnostic. Okay, it doesn't take very long. They go in, they take care of it. If it's just a simple procedure, maybe again 20-30 minutes. However, it can last a lot longer if they're going to do therapeutic aspects to it. And they can try several things if they're going to place a stent, etc. All that takes time, as when they go in, they look, they find a blockage, then they've got to remove the blockage. Then they got to figure out what they're going to do to stabilize that particular vessel. And they'll be putting wires in and out of this catheter, right? And it can be a little bit time consuming. And if they have to take care of more than one vessel, it's very delicate work. And again, it's all done via X-ray. So there's a camera up here and the provider is looking at this camera, and then he's literally, looking at the camera and doing the procedures and not looking at his hands. It's kind of like learning to type without looking at your hands. Okay, so the vessels are very, very small and delicate. I've got some great pictures that we're going to look at to talk about that. This is actually what it looks like to do a renal, and that's what they were doing. They were working on renal, just means your kidneys. They're doing a renoangiogram. So let's break these three pictures up. So here's obviously the kidney, right? We can see it very well. That you can see the little catheter wire right there. And actually your kidneys are very high up in your lower back. So there, notice here, those are ribs, right? So up into your rib cage, up in those floating ribs, are protecting the kidneys themselves. So he brought a wire up through probably the femoral artery, and it goes in here, and we're going to one kidney. They've inserted the dye, and that's why that's very bold, and you can see the vascular system, how it branches off like a tree. Okay, and then gets smaller and smaller. So, with my limited knowledge, it just everything looks pretty nice and perky and big and vascular. It looks good right there, doesn't it? In comparison, let's go all the way to the other side. And we've got a 63-year-old with incidental RAS, but look at these arrows. Now we're looking at these renal arteries is what these are. And there's obviously some blockage. There's a problem. So they've shot the dye in there, and you could see the little trees branching out and everything. However, look right here. See that segment? I don't know how well you can see it, but it's white, and it should be solid. And right here, see how that is very tiny? And it should look like this, nice and solid, right, with the dye. So we've got blockage in two strictures in two areas. This one's almost completely, cut off. It's not getting very much vascularization. And this one, you can see the little indent. Now let's look at this one. We're talking a major blockage here, because see how this is nice and thick? And there's no branches to the tree of this kidney. This is not being vascularized. This right here, this little branch they're pointing off to this arrow, there's a blockage here, and all of this down here is not being fed. We're getting no oxygenation, no blood flow to the lower part of this kidney, and very little to the top. It should look like this. when they put that dye in. Okay. You, of course, don't have to read these, but often when you're doing the coding, all of this stuff is at your fingertips because you get to see the chart, and it's all digital more or less. And for you to realize, oh, was this left or right? Well, look, it's left because you can go look at the imaging and stuff. And if you're trying to remember how it branches off or something, go in and look at the picture. You're entitled to look at that and see if you can familiarize yourself. Sometimes it takes a visual to be able to get that implanted into your head. I am a very visual learner. Not everybody, but I think a majority of people are. So when you can see that story in your head and play out because you got visuals to look at. Another reason I wanted to show you this is to show you the right and left. Notice here, we should be able to see the other kidney in this first picture, but they didn't insert dye in there. So that's why we can only see this kidney. It's the kidney that they're looking at. Whereas this image, obviously they know the problem is as bilateral, so we get to see that image of both of the kidneys, the renal artery branching out. Okay, that helps me. This is a picture I thought was very, very telling, and also to help you understand the anatomy. So hypoplasia is, if you don't know what that means, hypo means below, or something that's not normal. It would be below normal. And plasia is ultimately, when you break down the word, it means not enough cells. Okay. So what is happening here is we have hypoplasia of a common iliac artery in a renal transplant patient. Now, this particular scenario that I pulled off of a provider website, an educational provider website, this is a congenital hypoplasia. I just didn't type all of that out. And what it ultimately means is the common iliac artery, and the reason it's called the iliac artery is because this is the iliac crest of the pelvis, this arch right here. And so this is the artery that branches off, that goes off of the top of the pelvis, that would be called, like the iliac crest. So it's a common iliac artery. A lot of the vascular system is named after locational sites, so they're named after bones. And that's why when I teach the bones, I want people to know that the top part of this pelvis is called the iliac crest. Why? Because there's also an iliac artery that you may have to be aware of. And if you already know that's iliac crest, then you know, hey, that must be an artery that runs right off the pelvis. So this is the one side. This is what it should look like. All of these vessels, very large, feeding the lower extremities. This side right here is hypoplagic. It says hypoplasia, congenital. They were born with the artery system over here on the iliac, the common iliac artery is too small. Okay, they were just born that way. There's no blockage, there's no trauma. It's just too small. So ultimately, this person had a renal transplant. This patient had a kidney put in, another kidney. They don't show the kidneys here because actually the kidney is up high, up there, but I'm just assuming, I'm guessing, because there wasn't enough vascularization on that side, probably the kidney had a congenital problem as well. We're just guessing, but it would make sense. There's not enough vascularization on that side of the anatomy, and congenital, they were born that way, and so there was probably something wrong with the kidney. So be aware of things like terms like hypoplasia or iliac artery. You're going to see that. And in this case, we're going to talk about them going to the iliac artery. I wanted you to be aware of that. Now, another part of the anatomy of the vascular system that this case talks about is the abdominal aorta, which is this great big aorta right here in the center of the body. Notice those ribs up high in the ribs. Way down here is the iliac crest, right? And this aorta runs down through, but look and work where the kidneys are, way up high, right? Way up there by your rib cage, not low down in your low back. It's up a little bit higher. So the abdominal aorta, which I put an arrow here, is this great big large aorta. They are going to go through that in this procedure to get up to the kidneys, right? Femoral artery up through the abdominal aorta and into the left renal artery, and then you have the right renal artery, right kidney, left kidney. Look at this splenic artery. It goes to the spleen. Ah, that makes sense, right? Here is the posterior intercostal arteries. Costal means ribs. So the back vessels that go and supply blood around the ribs at the back of the body. And then you have like superior intercostal arteries that would be at the front of the body. Hepatic artery goes to the liver. And the liver does. It runs right along here. Let's see, right kidney, lumbar arteries run off the abdominal aorta. Oops. And I think if my little screen doesn't keep popping up on me, left common iliac artery, you see right there. And then, of course, the other one is the right common iliac artery that branches off. Okay. Very good. So now you have an idea of the vascular system. And I just realized I didn't pop up any questions. There we go. Oh, yeah. Someone had made, there's an actual, wait till you see the report. Like I said, it's kind of awful. But now let's talk about some other terminology that we are going to see in this report that it's going to be very important that you understand what it is. Peripheral vascular disease. It's abbreviated as PVD, all right? PVD, peripheral vascular disease. Do not, absolutely do not get that confused with PAD because that's peripheral artery disease. So what's the difference between PVD and PAD? Well, PAD is a disease to the arteries and PVD is vascular, but we're talking veins, okay? But it, I think PVD ends up being kind of a catch-all sometimes, and there are different codes for these in ICD-10. You've got to make sure that when you're reading that you know if it's PVD or PAD. Now, they're probably always going to write just PVD or PAD, but I think for the most part, you see PVD much more commonly than PAD. So just be aware of that. And then PVD can be broken down into a higher specificity. There is a code for just PVD unspecified. If you're going to be doing a peripheral procedure or anything that's a procedure on the vascular system of a person that has PVD, they're going to be very specific as to where they're going. So you're going to be able to get something better than PVD unspecified. But PVD tends to be a code like ICD 10's I-10 that you, hypertension that you memorize, especially if you're working with anybody like Medicare patients, because PVD is relatively common as you get older. Vascular system just wears out. Okay, so what is PVD? It is, and peripheral just means outside, not those main center, but think of the extremities, the smaller vessels. So they are the disease of the blood vessels outside the heart, right? The blood vessels outside the heart, not the heart, because that has a whole nother set of terminology and codes that go with that. And it is the arteries and the veins. Okay, so we're talking about the vascular system in general, whereas PAD is peripheral artery disease. no veins are involved. Okay, so see how it's a higher specificity. So don't get those, they're not synonymous with each other. Intermittent claudication. Now, you'll see claudication again and again and again and again. Ultimately, that means that the person is having pain, it's cramping, and they are limping. It is not the same as limping. Okay, there's a code for limping and stuff like this. Claudication has to do with the vascular system. It's a very specific thing that a person's doing. They're limping because they have pain and spasms in their legs because it's cramping, because it's not getting enough oxygen from the vascular system. But when you see claudication, and you'll see it a lot in any type of reports with older people, whether it says they have claudication or they deny claudication. Instead of saying they deny limping or having pain in the leg that makes them limp, they'll say denies claudication. And intermittent claudication, hey, that just means sometimes they have it, sometimes they don't, right? So there's medicine that can be given for claudication. If a person has claudication or intermittent claudication, that usually is an indication that they have some type of PVD going on, right? It's a sign or symptom. Now, does that mean you code claudication with PVD? That can be tricky because claudication is a sign and symptom of PVD. However, you may, if you think that you don't need to code it, you know, that could be touchy. You probably don't need to code it when a person has been diagnosed with PVD. Okay. The thing about that is it's caused by obstruction, and it's usually atherosclerosis of the native arteries. It doesn't have to be just the native arteries either. Okay, atherosclerosis then. So what's atherosclerosis? Well, we're talking about the arteries because it's athero, and sclerosis just means that there is a buildup of residue inside the arteries. Now, I always think of atherosclerosis as hardening of the arteries, but technically it's not. Okay, it's this plaquey deposit that does make the arteries harder, you know, because it's plaque. Think of that glass that you left with some water on your window seal. The sun came in and dried it off, and you know that lime residue that you have to use like vinegar and water to and scrub it all off to get it off, or you keep using your coffee cup or your coffee pot and it gets that lime residue. That's what we're talking about. It's a residue of fat instead of lime that builds up around the inside of the lumen, or the inside the tube of your artery. And quite honestly, this just happens with old age. Now, some people are more predisposed congenitally to have it more than other people. And you can be young and have this buildup of fatty deposit. A lot has to do with your diet and your lifestyle, of course, but you know, you can have a very slender, relatively young person that has atherosclerosis. You know, it can happen, but for the most part, it is a geriatric type condition. So atherosclerosis is that fatty plaque that builds up on the inside lining of the arteries, makes it less, it loses its elasticity because our arteries they don't use a valve system like the veins. They have that stretch, that elasticity, and there won't be any elasticity if you've got hard plaque built up in there. Now, native artery. I actually had to go in and, you know, I was really surprised when I tried to find the definition for native arteries, and my brain wasn't working too good today, because when we talk about a native artery, I knew what that was, and so I was going to, you know, just say what it was, but I needed a definition, right, to back up what I was saying, just not for me to tell you. And I came across this definition that says native arteries that I thought, this isn't right. This isn't right. And so I found another in Find a Code under native, and I was like, no, this is right. This is the right definition. So I talked to Skylar, I talked to Jennifer and some of the people there at CCO, and I said, what's going on? Is my brain, did they change something? What's wrong with my brain today? And Skylar mentioned, no, it's really the wording as far as it being a noun versus a verb in the way they're explaining it. So let's say a native artery. This is what I want you to remember, okay, about a native artery. And you will see this again and again in the documentation when you're dealing with, especially the heart, with the vascular system. A native artery is one that has not been touched. It's natural to your body, okay? That's what a native artery is. So don't forget that, and you'll be fine. But this description will throw you off until I explain it a little better. Used to describe an organ for which transplant or bypass has been implanted, for example, native coronary artery. But I added this note, prior to surgery. So the native artery is prior to surgery that it's been, whether they did a bypass in the heart and they took one piece of an artery and cut it and put it in a different area, connected it to a different part of the heart that had a blockage, or they actually took the venous vein from the leg and implanted it in the heart to bypass, okay? Then it's no longer a native artery, right? Because it's not where it was originally supposed to be. They moved it, they manipulated it, or they transplanted it. They took it from one part of the body and put it in another part. So whenever you see a code in ICD, and you'll see these that says of native artery. So if a person, some of the codes for cardiac, they're going to ask you more or less with the code, is this a heart that that we're dealing with just the native arteries, nothing's been manipulated or changed, or is this something post, native arteries? Have we moved them around? Okay. Now that you know what native artery, don't forget that, because you can't just jump out on the web and find it. You might get a description that's really odd, and you'll do what I did today and second guess yourself. I was like, no, it's always been the original pre-bypass surgery. That's where you see that term a lot, is for bypass surgery, native artery. Okay. Then always know you can always ask your friends and your colleagues and your peers, did my brain just go wonky or what? Okay, now I'm going to move this case over real quick, and you're going to get to look at the case itself. I made it very large. So let me go back up to the top, because this is the bottom. And I'm going to show you the codes that the person, I left it gray instead of black, so you'll know that this is the actual procedure, and then everything that I typed in is black. And you'll get a copy of this if you're in the CCO Club. So again, just copied and pasted what they said that procedure was, right? And there's your codes, the indication of what's being done. And I pulled those codes out. So here is the findings. They did an abdominal aortogram, normal size, severely calcified abdominal aorta. Now, think back in your head, you know where the abdominal aorta is. It's that large aorta that goes up along the spine, okay? This is a major vessel for our body. And we're seeing that it is severely calcified. So we got a lot of stuff happening there. Now, I'm not going to read all of this. I'm just going to give you some of the highlights that should jump out at you. Some of this stuff is just fodder. So there is large plaque at the level of the left renal artery. You know where that is because I showed it to you. And extending into the mid-abdominal aorta. So that went from the aorta, and it goes into the left renal artery. So far we're just talking about the left side, the left renal artery. Now we get into the size and some of the other parts of the anatomy. But note here, distal abdominal aorta is ecstatic with moderate calcified plaque. So it has plaque, but there's no aneurysm. Okay, so that's good. We didn't have a code for the aneurysm anyway, meaning there's no ballooning going on. Dissection of obstructive disease. So they're going to take out that plaque that's causing problems. Bilateral selective renal angiogram is what they're doing next. So the right main renal artery, they're saying a medium-sized vessel without evidence of any obstruction. So the right looks good, and the right kidney appears reduced in size though. So that's problematic, but medium-sized vessels, no obstruction. Left main renal artery is small, diffusely diseased vessel with 99% stenosis. Proximal means just close to the inside of the body. So that means when they're looking at the vessel from the midline, which would be like, think of your spine, proximal is going to be close to the spine, distal is going to be away from the spine in this particular scenario. So this stenosis, this hardening of the vessel is 99%. So there's just like no blood getting to that left kidney. The left kidney is severely reduced in size, so it's atrophic, meaning it's tiny. And it would be, right? You're not getting any blood. It's going to start shrinking up, shriveling up. Bilateral iliac angiogram. Well, because now you know where that's at, because we know where the iliac arteries are, right? Down here by the pelvis. The kidneys are way up here, which I can't see myself because I hope I'm in the screen. Sometimes I get the camera too close to myself. Make that, and so that way if I sneeze or something, I lose my screen. Okay, so you got your pelvis, the iliac crest, which tells us, if you don't know, sometimes they can tell if you're a male or female by the way the iliac crest is. That's how they determine the skeleton. So a woman's pelvis is very a woman's pelvis is very flat, more like this, and it tilts back, whereas a man's pelvis is very heart-shaped, round, with more of an arch at the iliac crest. Okay, and those arteries, remember, they branch out down low, and then the kidneys are up above that. So now what do we find from the iliac angiogram? The left common is a very large vessel. It's patent, mid portion, blah, 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 little undersized, but nevertheless, it's working. Left hypogastric artery is patent. Now, gastric is the stomach. Hypo would be below the stomach. So they go all the way up into that. Now, that one wasn't on our little diagram that I showed you, but that's up higher. So that's going to be kind of above the kidney. Left external iliac artery, medium size, it's about 40% stenosis immediately after the bifurcation, meaning when it forks off, with hypogastric, appears non-obstructive. So it's just a little bit smaller, but it doesn't seem to have any blockage, is what he's saying. Now, none of this we're not really coding yet, but we know where we're going. That's why I'm bringing this to your attention. So they go and look at the left common femoral artery. That's where they go in. It's calcified, 30% stenosis, left deep femoral, superficial femoral arteries are patent. Okay, now these are lower. These are down below the iliac, that iliac arteries. So femorals first, and then you get into the iliac, then you're going to get up into the renal, and then you're going to get the hypogastric, and you're just going up the tree, and it branches out left and right. Right common iliac artery, very large, only about 10% stenosis, right? All this. Okay, so you've got large, there is 80% stenosis in the hypogastric artery, and mid-portion stenosis, hypogastric artery, collateral, blah, blah, blah. We're just going up. So up high, they've got more blockage, it seems like, than they do down low, ultimately. Now we're going to move down to right external iliac artery is occluded entirely. That's not 99%. That means there is no blood getting through the iliac artery. So picture in your mind, again, where we saw where the iliac arteries are. The iliac artery is right there above the iliac crest. There is no blood getting through there. Right common femoral artery, which is a little bit lower than that, is calcified, chronically occluded with only bifurcation to the right deep. Okay, so ultimately, in layman's terms, we're saying that the right femoral artery that branches off, and we're coming down this way, that it bifurcates, so it branches off into two. One side is occluded. It has only bifurcation to the right, deep. Aortic arch angiogram, so they go all the way up into the heart, and the aortic arch way up into the heart. Let's see, and they found that type 2 aortic arch with moderate calcification, so they're just full of plaque all over. Let's see, and no aneurysm, but they've got a little bit of plaque. And this innominate artery, I may be saying that wrong. It's got some stenosis, gives rise, blah, blah, blah. We don't care about that. Right carotid artery. Okay, now we've gone all the way down from the femoral artery, which is down by the groin. We've gone to the iliac, which is right there at the top of the pelvis. Then we into the renal arteries, which is by the kidneys, with the hypogastric arteries that are below the stomach. Then we went into the to the heart in the aortic arch, which is right there at the top. Then we're going up into the carotid arteries up here in the neck. And there's 50% stenosis and 70%. So this is where we're getting into the brain. We're cutting off blood flow to the brain. Right external carotid artery is chronically occluded, meaning it's been occluded. That's been there for a while. And left carotid artery, large calcified vessel, 90 to 90% stenosis. So they're just not getting enough blood to the brain. When you have that much. And it can't get that elasticity that it needs. So left external, again, chronically occluded. Left subclavian, the subclavian is under your collarbones, which are your clavicles. If they're going to do any procedures in the heart where they need to put in any type of a, not a peg tube, that's into your throat and stuff, but they want to put in a port of some kind. They usually go into the subclavian artery. If they can't get into this, they'll go up into the carotid artery. My mother's port for her chemo is up in the carotid. They try to avoid that and stay under the subclavian. Well, just for one thing, it's more comfortable, but they couldn't get hers, and sometimes they can't. They can't get in there and get a good access. So we're looking throughout the whole body, and this person is pretty stenosed and plaquey all over the place. Let's see, vertebral arteries, stenosis subclavian, see how it's branching out. Okay, now right lower extremity angiogram. Now we're going femoral arteries. We're going to go start looking at everything at the lower half of the body. 80% stenosis in the right deep femoral. Visualized proximal mid right superficial femoral artery, which again, don't let all of those adjectives freak you out. They're just the main ones you need to know. Are they distal or proximal? When they say deep, that really doesn't mean anything to you. It doesn't need to. And where they're at, femoral artery. Okay. Distal, and let's see, the SFA and popliteal angiogram, that's going down all the way into the lower parts of the legs. Okay. Now, that's everything that they found when they did these procedures. That's what we just went through. They haven't done any procedure yet that we've read. All they've done is tell us what they found during the procedures. So what did they do? Now I'm going to go through this kind of quickly because we've already got a picture in our head where the pathways that they went because of the findings that they found. They more or less, this isn't a scope, but But if they were scoping, it would be saying they scoped them everywhere. They looked at every major vascular area in this person's body. And quite honestly, they can do that pretty quickly because there's a contrast, and they can see the contrast wherever they run the X-ray machine. Okay, so they went in. This is all fodder. We don't need to know how they were prepped, that they were in the cath lab. We do need to know their access. Where did they go in to access the vascular system? It's almost like it's the stick, right? So it's the common femoral artery. Left common femoral artery is where they went in, and then they just went everywhere from then. They did an abdominal angiogram and a bilateral iliac angiogram. Abdominal arteriogram means they did that abdominal artery, right, that main artery. And then they went bilateral to the iliac angiograms. Remember, because we know what they found. Then they went, let's see, the distal abdominal artery, they went down. And let's see, then it says selective bilateral renal angiogram. They went into the renal artery and looked at the kidney. Right lower extremity angiograms, because they did the femorals, right? They started going down. The aortic angiogram, they went up into the heart and did the aortic arch right here, aortic arch angiogram. And selective right carotid arteries right here, and they did subclavian. Selective left carotid, and that's next to be selective subclavian. So because of the findings, and that there were so many findings, we just by reading those, and quite honestly, I find those more interesting than procedure itself, but you have already a picture of the pathways that they took because of the findings. We know that they did every major hub of arteries, and they went left and right and looked at both sides. So the entire procedure, they used 82 cc's of contrast. We don't care about that. We could care less how much, but if you read these a lot, you would know that 82 cc's of contrast is quite a bit, and that's why they got a picture of the whole body's vascular system. A lot of times they're just going to do the kidneys, or they're just going to do one, or a specific part, but they really gave this person a real look over. Let's see. That's we don't care. Local anesthetic, we don't care about that. And all this is that they numbed the area with lidocaine before they stuck them with the tube in the femoral artery. And then they drugged them, more or less, layman's terms, right? Procedural approach, again, this is just devices that they were using. We don't care about that either, unless we're needing to go out and picture something. The contrast that they used, the only reason you would need to know this is the fact that because it's listed, that tells you they did use contrast, right? So if you know when, if this is left blank, then you know the procedure that was done was without contrast. So that's why you would need to know that. The equipment that was being used, probably don't even need to know that, okay? Maybe not, but I would say that's fodder for you. We really don't care about all of this stuff. The sedation, again, we know that they gave them a little lidocaine to be able to stick them so it wouldn't hurt, but and they don't, another reason you use lidocaine is because it has also an ingredient in it that stops bleeding. So that's why they do that. But they gave the guy Versed and fentanyl, which lays you flat. It's your sedation, but it's conscious sedation. They don't have to intubate you. Okay, so you can breathe on your own and everything, but you are pretty much out of it completely on these two medications. And the rest of that's fodder. We don't need to know about that. The EKG, all of this is stuff that was during the procedure. We don't care about that either. It's fodder. Conclusion. This is important because these are diagnoses again. Severe diffuse peripheral artery disease. You betcha. everywhere they went, the guy had occlusions and plaque and stenosis, right? Every one of those little hubs that they went and looked on both sides, the laterality of it. So that tells you that our patient has PAD, peripheral artery disease, PAD, and it's profuse all over the place. And it's severe, which that doesn't matter to us. Chronic total occlusion. Well, now they're going to start breaking up all of these occlusions that we already read in the findings, so we don't care about that unless we need to go back and look to verify where they went, but we know they did everything. And we're going to have a lot of codes because of that. And quite honestly, recommendations, we don't really care too much about that when you're going to do the CPT aspect of it. You know, if you're doing something else like RA work and everything, absolutely, you're very aware of this right here because you're going to expect possibly more procedures and findings to reveal themselves that you can code. But just for this procedure, recommendations, we don't care. And Plavix, oh yeah, they're going to definitely put them on a medication. This is what our person that submitted this, and I did not put the person's name down. She was, you know, with a particular group. This is what she's thinking. Okay. Now, last time we did this, I went and pulled out all of the codes of what they were thinking, and then I compared them to the codes that we came up with. But I didn't want to do that this time because, quite honestly, we're looking at a lot of codes here. So I wanted to show you. This is, and we're not going to look at this here. I put it on the slide deck. We're going to jump back over to the slide deck. So you can go back and read how she states that we did this, what she's thinking, and the diagnosis codes. So honestly, no, I don't think I did put that. Let me go through that real quick. I didn't also, forgive me, I didn't put all of Jennifer's credentials because she's got a whole arm length of them, just lots of credentials. So you can go back out and look at her credentials. So she's saying, okay, in my opinion, she's reviewed this and she's looking at this, and there's a few things that jumped out at her also that she's telling you. And she says, and I'm just going to highlight some of these. So review the procedures noted, states abdominal aortic angiogram, and then how far they went it and everything. That would be the 36200 and 75625 and the modifier and everything. Okay, that's what you think. She says, however, this is the kicker here. I probably should have highlighted this or underlined it because this is what she's saying. The next procedure is selective bilateral renal angiogram. Okay, and they went into the right and left main renal arteries. So that would be 36252. Okay, and then it says if you do that, that negates 36200. But when you look at the codes, you look at those two codes, you can see why 36200. The reason it negates it is because you're going farther. When you go farther, you just use that code. You don't have to do the first code. The right lower extremity angiogram, bifurcation, again, just means that it's split like the tree. The mid-right iliac is, and then she listed those codes. The next procedure is, okay, and that's the 36222. However, and notice how, here, I'll just underline this. I should have done that. Nothing was seen specifically, okay? The next procedure is the right carotid, okay, and that would give you 36223. One of the codes suggested to use is for angio or of intracranial carotid circulation, which is, you know, but they did not mention doing that. They didn't go up into the intracranial area. Let's see. So you'd be used 36222 and your modifier, and then the last procedure is the subclavian, and then this is another thing that's very, very important. The diagnosis indicated, and we already talked about these diagnosis codes, would not provide medical necessity for all these tests. Very important. So you could possibly pull out these particular codes for the I-70.213. You may have to speak to the provider for the diagnosis to support the medical necessity. That's something that so many people forget to do. They are just so driven on, I got to capture all these CPT codes, but without the diagnosis codes to back up why you're doing all these other procedures, it's not going to get paid for. And that is Jennifer's billing experience. She's also a certified biller. That's where that knowledge kicks in and says, hey, wait a minute. You could get all these codes right for the procedures that are done, but when you go to bill this, the codes that the provider has indicated as the reason why they did the procedure in the first place, they don't give you medical necessity. So that is something where it could be several reasons, whether the provider just failed to put that on there, or they got in there and started seeing all these problems and didn't follow up with the other codes. Okay, so what should we code? Now, this is what I took and put on our slide deck. So let's jump back to the slide deck because it's a little bit easier to see. And I broke it down step by step. Oh, Barb see some spelling errors in femoral. You know what? There were spelling errors in all of those, and I let some of, I corrected some of them and some of them I didn't. So thanks, Barb. Keep in mind, you'll see those. Okay, so the two diagnosis codes that we were given for this procedure, I-73.9, the PVD, which can have arteries in it, but it was unspecified. This includes intermittent claudication. It includes peripheral angiopathy, not otherwise specified, or spasms of the artery. And then the I-70.213 is atherosclerosis of the native arteries, because no bypass or anything's been done, of extremities with intermittent claudication bilateral legs. So we are having claudication bilateral legs. They're limping and having spasms. She is suggesting these codes. Now I'm going to read these off mainly for transcription. 75625 with modifier 59 and modifier XU, and that's HCPCS modifier. 36252, 36245, 75716 for the right, 36225 for the left, and 36222 with modifier 50. So let's talk about what those codes are. The 75625 is the arteriography for the abdominal artery, and the supervision and interpretation, that's included. The 59 is a distinct procedural service. The XU is unusual, non-overlapping service. So the use of the service that is distinct because it does not overlap the usual component of the main service. So we went above and beyond kind of what they planned to do. There was overlap. 36252, selective catheter placement, first order. That means where you first go in before you start bifurcation or splitting off, first order. They did the main renal artery and accessory renal arteries. After that, you really don't need to, the rest of this we don't care because this is locational. The rest of it we already know. But we needed to know that we were doing the renal artery and also any of the ones after that, off the renal artery. Next one, 36245, selective catheter placement. It's going to say it on all those. Arterial system for each order, abdominal, pelvic, lower artery branch within a vascular family. So you're telling me, well, what's a vascular family? That is where it bifurcates, okay, and it splits off. So think of your tree. You got the tree branches off like this. So everything that branches off over here is one vascular family, and then up here is another vascular family. Angiograph extremities, bilateral. We did do that, 75716. And then we have 36225, the placement of the catheter, subclavian or inundated artery, unilateral with everything else that they did. Okay, so again, we're just moving up. And then the 36222, selective catheter placement, because they all say that. Common carotid or innominate artery, unilateral, any approach. Okay, and then it goes on to say some more of the extracranial carotid circulation, blah, blah, blah. And it's a bilateral procedure, so we have to use modifier 50. With modifiers, it really depends who your payer is on how sometimes they want you to do that, whether they want you to list it twice with a left and a right, or you can use the modifier 50 for bilateral procedure. Again, it's up to whatever your payer prefers. And if you say, well, which one is it? Then I would tell you, call the payer and find out. So often with billing, and a lot of the billing questions that we get in the CCO Club, and just as you're doing your coding, it really truly is answered differently per state, because the billing rules for state to state change. So Blue Cross Blue Shield of Texas is not going to be the same as Blue Cross Blue Shield of, like New Jersey or Florida or Missouri or wherever. It's not going to be the same. And but for the most part, if it's Blue Cross Blue Shield, they want it done one way. If it's United Healthcare, they want it another way. Medicare wants it one way, et cetera, et cetera. And the only way you know it is to call them and find out. Go to their website, inquire. If you're doing the billing, you need to have an open communication with them, and they don't mind the questions. So once you know, you can write it down and be consistent with it. Tell everybody in the office, hey, this is what Blue Cross Blue Shield wants. And then 6 months later, when it gets denied, you call them and say, hey, everything was right. And they say, oh, by the way, yeah, we changed it. Now we want you to do this. That just happens. But it also means you have to have open communication. Most billing questions can be answered used to be with the phone call, we used to say, but now it's usually with an email. And that's it. Do we have any questions? I see Whitney said, I have heard of you're going to make me say that word again, Whitney, that I can't hardly say. Innominate artery, pronounced like you are going to nominate someone. Thank you very much for clarifying that. So innominate. I think you're right. Now that clicks in my head and I'm remembering that. One of the things that I do when I'm pronouncing, and mind you, sometimes it's regional how we say things, and I always used to tease Laureen. She says button, and I say button, or maybe I'm not even doing it right, but we put emphasis on different parts of a word, and if I can't get something in my head, we went to a conference one time, I can't remember where it was at, and her and Chandra were giving me a hard time about the way that I said integumentary. I say integumentary, and she said, no, it's integumentary or something. I don't know. I was doing it wrong. But again, thank you very much. You do need to be able to pronounce the words properly if you're going to state them to a provider, or you want to make them feel good. Say, is this innominate or is this, how do I say that properly? And they'll eat it up. They love it. And don't correct them if you think it's another way. Anyway, just another way to keep the conversation and the dialogue open between you and the provider that you have to communicate with. A lot of times you can go in and Google it, and they'll let you hear it. I've done that too, because if my head's not working, I put accents in all the wrong places. And if I do it once, then I repeatedly do it for the rest of whatever I'm talking. That's why I have a hard time not saying that person is from Canada instead of Canada, because you say Canadian. I teased my children one time with that, and that gets stuck in my head. Boyd can appreciate that because he's from Canada or Canada. Any questions, guys? Anything else? If not, I think we did good. I'm just looking at the clock here to see how we did. Very good. All right. So if you do have more questions that come up, there's your resources that'll be on your printout. Don't forget, this came from the CCO Club. And join the CCO Club. You can ask questions and get people like Jennifer, Skylar, we've got Susan, we've got lots of subject matter experts in there to answer questions for you, as well as other people that are students, people that are professionals in a specific area. Wouldn't maybe say they wouldn't call themselves subject matter experts, but they're working in that area. And you can keep a dialogue going and help each other with scenarios like this that are quite mind-boggling when you have to break them down. It's always good to have another pair of coding eyeballs look at them from a different perspective. Okay. Well, thank you very much. Again, don't forget to like and subscribe if you're watching us on YouTube or Facebook. That helps us, and it helps us get the word out about some of the videos that we do for CEUs. And real easy to join the CCO Club. If you are not already a member, just go to cco.us/club. It's just a nominal fee every month, over 100 CEUs that you can have access to, as well as having access to all those subject matter experts. Feel free when you're in the CCO Club to submit scenarios, encounters, unique things that you come up across, because we will in turn turn that into a teaching moment for others. And so I didn't mention who submitted this, but thank you very much. We appreciate it. I think that it was beneficial to even us at CCO as we looked at this and increased our knowledge base on interventional radiology. All right. Thanks, guys. Have a great evening.